Good morning. This is Steve Stites, Chief Medical Officer at the University of Kansas Health System. Back with you today. Had a little medical emergency I had to go take care of yesterday. Not in me and one of my patients. But we're back today here at the Dal Simons Family Studio. So happy to be with all of you. On the screen is Dana Hawkinson, Hawkeye, who is at some place where there's a Texas A&M flag behind him. He keeps raising up his KU Jayhawk cup. Now, don't do that, dude. You're going to offend a bunch of people. Show us your Jayhawk. That's better. There you go. He just rolled out of bed. You can see that as you look at him. He's got some kind of funny-looking gray shirt on. His hair's going straight up. What do you know about that? On my left is Bruce Toby. Bruce is the chair of orthopedic surgery, a good friend of mine. He has done a great job. It is our leader of orthopedic surgery, and he's here to talk with us a little bit today as well about the things going on out there and all things orthopedics and COVID, but how the operating room is bouncing back, youth sports leagues. This guy has had a vision for sports medicines that led to KU being the home for the Royals and the Chiefs when it comes to medical care. Dr. Dawood Sayed, I hope I said that right. That's pretty close. He's one of our anesthesiologists. He's president of the American Society of Pain and Neuroscience. He's going to speak with us a little bit about what's going on in his world as far as COVID, pain, and chronic issues related to that and COVID, as well as the safety of the operating room. Before we get started, though, we always turn to Doc Hawk. Hawkeye, how are we doing today?
Hi, we're good. You know, I have been up for a while. I showered, got my coffee ready. So this is just how I look. I can't really do anything about that. You know, over the last 24 hours at the med center, at the health system and the hospital, we have had anywhere from 22 to 24 COVID patients in. Right now we have 22. We've had some discharges. There are 9, however, in the ICU and 6 of those on the vents. But as I talked about yesterday, I think we should not focus on those numbers. Instead, what we need to focus on is that we are having an amount of discharges every day. But unfortunately, we are continuing to have the same amount of new admissions or even more admissions than we are discharges. And I think that speaks more to the trends that we're seeing. In addition, there was a question about the age ranges yesterday. In the ICU, we have a patient as young as 29. So in the ICU, we have an age range of 29 to 80. In fact, the 29-year-old is actually on the vent. And on the floors, we have an age range from 24 to about 70. So we have a very broad age range, and even the young people are being affected by this.
And what we're seeing, Dana, I think, is we have shifted, as have the positive tests, to a younger age group. And the dominant age group right now is 20 to 29. And what we know is that's the most social age group. And so it's clear that as society has reopened up, the bars have reopened up, and especially young folks have started congregating together again, the virus has taken off. And the pillars of infection control have not changed. And when you follow them, they keep you safe. And when you don't follow them, you are at risk. Yeah. So I think this is our new equilibrium. It may go up higher as more people get infected. We'll see. We're going to hope that the rate of transmission from one to another and the rate of admission stays the same or even drops. Because if we know, just as we bent the curve before, if you practice good infection control, you'll bend it again. Mm-hmm. So how are things down in the operating room? How in the sports medicine and the youth sports world?
Well, things are restarting, and that's a good bit of news for us.
It is really good.
In the middle of March, as you know, we shut down, and orthopedics shut down about 90%. And now we're in the restarting area, and we actually have done quite a bit of volume, always trying to do it safely. And particularly what we're trying to do is to make sure that we take care of our patients who need to have surgeries. And one of the things that I think was difficult for us is that we were shut down with the idea that these were elective surgeries. And although that word sounds good, what it actually means is that we're shutting down needed cases. You know, these are all patients who need to have surgeries to alleviate pain and increase their function. And to stop those surgeries, I think, put a great deal of burden on some of those folks. And so we're so happy that we're finally able to start taking care of those patients.
I bet they're happy, too, because I know there are probably people with a lot of sore joints, so we're happy to get that taken care of.
They are. You know, in orthopedics, you know, again, I'm a bit biased, but we think we do a good job, and our patients often do very, very well. And so it's nice to see the patients back again in a very safe fashion. And one of the things I tell my patients is that there's no safer place probably than in the operating room, because we're used to masks, we're used to gloves, we're used to sterile technique. And so I think that we're able to do our surgeries very safely at this point. And I think it's a great credit to the leadership of the health system that we're able to do so.
Yeah, well, thanks. But, you guys are the premier orthopedic group in the region. I mean, you take care of the Chiefs, you take care of the Royals, you do amazing things, and now you're busy again, and you're really kind of back to full steam, right? I mean, things are really going along pretty well.
We're doing quite a bit of volume. We have some pent-up demand that we're going through, and so we're trying to see more and more patients, again, safely. One of the things we're trying to do is increase our hours, and we're trying to do clinics which we think are helpful to our patients in that they are after hours, and so many of our patients need to go back to work, and so we're trying to see patients between the hours of 5 and 7 and make sure we can see those nice folks without them taking off work.
And, I keep saying Chiefs and Royals. I should add Kansas Team Health and the University of Kansas to that, right?
We can't forget that.
No, we can't.
And then also the multiple high schools and middle schools that we take care of also.
Yeah.
Sports medicine has become a big deal for us.
Yeah, it's a really big deal. Talk to us a little bit about youth sports. What do you think? How's that going around COVID-19?
Well, it's obviously restarting, and obviously what we need to do is have those individuals abide by the rules and regulations of the health system and the state of Kansas. And I think with that, you can probably be very, very safe with it. But I think we need to be vigilant in that the COVID-19, as you've pointed out many times, is still out there.
Yes.
We can't forget it.
Yeah, not false news for sure. All right, so how's the world from your perspective in both the operating room and in your practice, and how is this affecting people with chronic pain?
Yeah, it was an interesting dilemma, as we function here in the Mark Asher Spine Center, where our chronic pain clinics are located. Pain patients presented a very interesting dilemma in the midst of this pandemic. Really, some people would classify some of the procedures and treatments we do as elective, but as we know, people that suffer from chronic pain, none of them really thought that their pain was elective. They really thought it was urgent. So we also had another really interesting thing is that in the midst of this global pandemic, we're actually crawling our way out of an epidemic, which was the opioid epidemic.
Yeah,
so those patients, that really we were really starting to make really good progress in following them very closely, risk mitigation strategies, getting them in for minimally invasive interventional pain procedures, which helped us to reduce the opioid use in those patients. Really, all those things really stopped. And then our orthopedic colleagues were not able to offer the joint replacement surgeries, the spine surgeries that really help those patients in chronic pain. So as all those things stopped, we've found maybe potentially a disturbing trend where we're reverting back to potentially opioid management, because that's one thing you can do remotely and send a script to the pharmacy. So we've really been happy that the health system and under the leadership of many people like yourself have been able to open up our clinics safely so we can get these patients back in, so we can start to again provide those really we think, not elective, but very urgent, critical needs, pain management strategies, so we can avoid, going backwards back into that opioid epidemic that we were.
Yeah, and that's a great point.
Of.
I hadn't thought about that, but with telemedicine not getting to come in and get things done, or not see you, then opioids become a fallback, and man, that is a tough fallback as we pull out of that epidemic, which is America's really struggled with.
Yeah, and we know that most people that get a prescription of an opioid, the majority of them are not going to develop a problem. But we do know that the numbers of people that will get that is sizable. Out of every 100 people that will get their first opioid script, probably 75% will use them appropriately, but 25% of them will misuse those. Out of those 25%, then 10% will actually develop an opioid misuse disorder. So when we talk about how we've been dealing with a global kind of this whole country in this midst of epidemic, there potentially could be some problems that arise with opioid misuse. And then you also exacerbate that people not being able to get surgeries that they need in developing chronic pain syndromes. You can develop chronic pain within as short as 4 weeks. So we talk about this whole kind of time period of what we've been dealing with. A lot of these things may bubble up to the surface.
Yeah, that's really a great point. And I know you're happy to take care of them. You're happy to take care of them, and it's great that you guys are all here. Dana, as we look over the news, I'm not seeing anything brand new about therapy here in the last 5 or 6 days. It's been kind of a quiet time. What's out there?
Yeah, again, what we're looking for, what we're using, a remdesivir. I think we are still needing to use the steroids. We're using the steroids. It has to be at the appropriate time. Convalescent sera is still extremely important in this. And then just overall, the non-viral, antiviral or anti-inflammatory, such as the anticoagulation to help prevent or treat the blood clot. That's really all it is. There's also some of the tocilizumab, which again is a compound to help decrease the inflammatory state. That data is somewhat equivalent. It may not help as much. We are looking at other things such as specific monoclonal antibodies, which are just specific antibodies for the virus that we can produce in a lab. That may show some promise as well. But as far as that goes, the vaccine trials are still underway, and hopefully those will turn out to be very efficacious. But that still will be some time away.
You say tocilizumab really quickly 3 times.
We just say Tosi.
Tosi. Okay, and what I also really want to know is, are you a drummer? Because I see a big drum set behind you.
No,
Okay.
I'm staying with relatives, and one of the little cousins is a drummer.
All right, well, there you go. Well, hopefully they don't want to be on the show as well today.
No, they're sleeping.
Jill, let's open up to some questions this morning. I bet we already have some.
We do. Do you want to see if media?
Oh, yeah, media. Any questions this morning?
Okay.
All right, here we go.
Community has lots. This is one we have not heard before.
Okay, we're ready.
We want to know if mosquitoes can spread COVID-19.
All right, here we go, Hawk. I even can answer this one. The answer is no, fortunately. It's really spread from human to human. It's got to be droplet. That's not a bloodborne disease. It's really a droplet disease. So, yeah, it's good news.
All right, Mary asks, is social distancing decreasing the effectiveness of our immune system to other bugs like streptococcus?
You know, we hear that question sometimes, Dana. What do you think?
The answer to that is the same as the answer to the last question. No. Again, our bodies are always, at war with other microorganisms. We are always coming into contact with other microorganisms. The physical distancing, the hand washing is not going to reduce the immune system at all. We are still inhaling particles, and the area that we live in Kansas City, there are a lot of fungus in the air which we are able to inhale, and if you have proper lung function, you are able to get those infections out, get those microorganisms out. But our body is constantly being bombarded by different types of microorganisms, whether that's viruses, bacteria, fungus. So just having the physical distancing and the hand washing is not going to reduce your immune system.
There is that fear out there, though, that and we hear it from time to time. Gosh, if I have a vaccination, I'm going to be in trouble. My immune system won't work. We just have to remember that we're colonized by bacteria and fungus everywhere. Our gut's loaded with it. In fact, it's this very important relationship, because without bacteria, your gut doesn't work right. So you're constantly have bugs around you. We have it in the mouth, we have it everywhere. And that's the reason that in the operating room, guys, you have to take special precautions, right? Because even without COVID, talk to us a little bit about all the things you do in the operating room to keep people safe.
Well, we do several things that are new, and one of them is that we're very careful about the intubation process, because there is potentially aerosolization of the virus. And so what we do is after someone is intubated, during that time, actually, all the people leave except individuals who have appropriate personal protection equipment. The surgeons leave, the circulators leave, the scrub nurses leave, and then we wait a number of minutes. It's now 6 minutes we wait before everything sort of disperses down, and then we enter the OR. We also are and we do the same process, by the way, when the extubation process occurs. So what we see is kind of delays our surgery somewhat, but it's one of those safe issues that we do. But otherwise, what we do always in the OR is we go after sterile technique. And with sterile technique, that means we try to keep the rooms as clean as possible. We have special ventilation in the ORs, which enhances the safety. And of course, we use gloves and gowns and make sure that all of our equipment is sterilized. And so there's these standard precautions, and there are precautions on top of that we're utilizing during the COVID pandemic.
And you seem to have a pretty good immune system. You're a marathon runner. You do all sorts of stuff to stay healthy. So I think all that mask wearing has been good for you.
I think so, too. And just as an aside, I think that fitness is a good way to kind of deal with the COVID-19 disaster. One of the things I do whenever I see a patient, the first thing I ask them is, how are you coping with the pandemic? And how are you getting by? And some of the people who are doing the best are individuals who have exercise routines, who are maintaining their fitness and their wellness by doing some type of physical activity. And so I do think there's great value in that. I had a patient just the other day who, she's in her 70s, and she said, "Dr. Toby, I'm worried." And I said, "What are you worried about?" Because otherwise she's always on the very pleasant and optimistic side. She said, well, I'm worried I've become addicted to my walking. And I said, well, how many miles do you walk? She says, well, me and my friends, we walk 5 miles every day.
That's the best.
And then afterwards, she says, we share a bottle of wine and we solve all the world's problems. And I said, don't you worry about this type of addiction. And I will ask you, I think that's probably okay, right?
I think that is
better than opioids.
No, I think that's exactly right. I think people that, in our practice, especially people with chronic pain, there, a lot of them have a lot of psychological comorbidities, depression. So we ask the same thing, how are you guys doing? How are you dealing with this? And I think the ones that are getting out there and trying to figure out a way to stay active are doing the best right now. They're taking their walks, they're exercising, they're being creative about the ways they're doing it and being safe. But I think those patients are doing the best.
I think you guys are music to my ears. I tell my patients the same thing all the time: exercise, exercise, exercise. And since COVID started, I've been on twice a day. I get up, I walk 1.5 miles in the morning, 1.6 miles with my dog around Loose Park, and then back in the evening, I'm back at it. I usually do yoga or a little floor Pilates in our residence, and I do go to an exercise class now a couple times a week, but it's outdoors and people are 20 feet apart.
Right.
And it works. It's the best, and I think those things really help all of us. Talk to us about what you're doing in the clinic to keep people safe.
Yeah, so I think analogous to some of the things that Dr. Toby mentioned in the operating room, a lot of the procedures and stuff we do are done in a procedural suite. So with the pandemic kind of hitting us, it really allowed us to kind of look back at our processes, and I think a lot of the changes we've made have been for the positive. So
I think we're going to keep them. We're not gonna, I don't think they're going to go away.
So, some of the things we do for when a patient comes in for a procedure now, I think, one, optimize, their patient experience. There were a lot of handoffs that happened before. There would be a specific nurse that saw them preoperatively, then there'd be a procedural nurse and a postoperative nurse. In order to kind of limit patient exposure to different healthcare providers, we've really just kept one patient with the same nurse throughout the whole process. What we found is patients are more satisfied, we're limiting exposure, and actually we're more efficient. Patients are getting in and out much quicker. We're really not using waiting rooms anymore, which is really amazing.
Isn't that is a, if you would have said that to us prior to COVID, we would have said, oh, you have to have a wait. And now you're like, who needs a waiting room?
Prior to COVID, I'd walk out there every once in a while, and the waiting room would be filled with people.
Right.
Our volumes are pretty much right back on par with COVID, and actually in June maybe we'll be a little bit higher, and we're not using our waiting room. I think a lot of that is just looking at our processes. So there are some positive things that have come out. We've looked at, scheduling more efficiently. I think patients are happier, and their experience is good. So I think all of those things are keeping patients safe, but maybe there'll be some positive improvements as well.
I'm really impressed by some of the things that have happened. Okay, Jill, I bet there's another question.
There are a lot of them. Monty, his is kind of long, and it sort of reads like that he might have had some issues with getting opioids while there was because of restrictions that were in place prior to COVID. He's wanting to know, if not opioids, what options do you have?
All right. I think that's your question.
Yeah.
Since you're the pain guy.
Yeah, so I think, what the positives that have come out of the opiate epidemic is that it really forced the medical community, our surgical colleagues and interventional pain specialists to really look at different alternatives. So we have a number of ways to deal with pain. So say, for instance, chronic low back pain, which is really the most common cause for people to get an opioid prescription. We have simple things such as nerve blocks and epidural steroid injections. But we have a number of other treatments even beyond that to help with those. If you're looking at medications, there's anti-inflammatories, very low-risk muscle relaxers and nerve pain medications that can also be good options. There's still going to be a small proportion of patients that will require opioids, but when we do provide those opioids, we want to put them at very regulated doses and make sure those patients are being screened properly for use and abuse. So I think opioids are still going to be present. They're still necessary, but we really need to be cautious when utilizing them.
Yeah, it's important because we don't want to create that 10%.
Exactly.
Yeah.
Judy asks, how long after I have knee surgery can I donate blood?
Oh, how long after you have to wait a while?
She's had knee replacement surgery.
Yeah,
and
now she wants to
know,
donate
can I go
blood.
and how long should I wait?
Well, I think it would certainly make a difference if she received some blood products during the surgery. I have to say, I don't know exactly. I might defer to either Steve or Dana about that question.
Well, we'll probably defer to the folks from the blood bank who are back with us tomorroll. We'll ask them that question.
Perfect.
So tune in.
I'll stay
We'll be real
tuned,
specific. Yeah, that'd be great. I think it's at least 6 to 8 weeks, Dana, but we'll ask her tomorrow. Kelsey will be back with us.
Stephanie is a heart patient. She wants to know, if I wear a mask, can I go shopping with my friends?
We talk about that a lot, Dana. What's safe and what's not safe? What's risk and not risk? How about you and I take the heart patient on?
Okay. Yeah, I think that, again, we always talk about look at your individual risks. We have talked about what we can do to reduce the risk, wearing the mask, physical distancing. Can you be physically distanced when you're shopping with those people? The other thing is, of course, good hand hygiene. So I think if you can do those things, but if you're going shopping, obviously you're probably going to be in a mall or in a store. That's another confined area. You're probably going to be there for greater than 10 minutes, 15 minutes or more. That does pose a risk. I think if you could try to maintain social or physical distancing, are you going to be in the car with them? Because driving to the store poses another risk in that small confined area. And so taking all of those things into account, certainly there's the possibility that you could do it and everything would be fine if you could follow those steps. But if you can do that, then that is really what we're looking for.
I think it's funny. We've said it before. Life's a balance, it's a journey, and you have to find it. God, it sounds like I've been meditating or something. And I think that's the kind of question where it's all about the relative risk. How bad your heart disease? If you have a really bad ejection fraction and you're short of breath at baseline, I'd find somebody to go to the store for you, or try and do one of those shoppers who can bring you the food, because that's a little more risky. Your disease is relatively mild, and you can get to the store with your mask on and your hand sanitizer in your pocket. So you kind of put it on while you're in the store, and you can definitely do it when you're out of the store. And go to a store where you see other people wearing masks. It's different. You go to different stores, and sometimes the culture is pretty good. They got a lot of folks all wearing masks. You go to other stores, nobody's got a mask on. Bad store for you to be in. Go to the store with the masks. Pick and make good choices. If you make good choices and choose wisely, you can do pretty well. And I think you can really stay safe, even in different environments. Jill?
Brian says it's good to see Dr. Toby on. Apparently you helped him or a friend, so I think that's always kind of fun.
Thank you, Brian. Good to hear
you have
from
at least one beer there, right? Jean is asking, what are your thoughts about youth drama practices with large groups of kids in a small indoor space and lots of singing?
I'm in pain, Dana. I'm in pain on this.
Yeah.
Go ahead.
Yeah, that hurt. Certainly, I think there probably are some drama or other camps that can be done outside. I think the real concern here is the indoors, the amount of people, probably the time you're together. We know that infection occurs in those types of situations. It's been well documented. I think it's pretty dangerous. We have been saying recently, based on some indirect evidence, that maybe children, those younger than 18, don't get the virus, aren't as susceptible to the virus, and don't spread the virus as much. But that doesn't mean they don't. That just means that it's not as much as, say, adults. But again, that's based on indirect evidence. I think that situation continues to be very risky, not only for those kids, but also for the instructors as well.
Yeah, I mean, that's like, I promise you there will be coronavirus at that camp. The coronavirus will be spread, and those kids will take it home. And the only question is going to be, how good of a spreader is a kid? As you said, more recent evidence says kids may not be spreaders. It's kind of like tuberculosis. Kids don't spread TB either. Even if they get it, they don't spread it. And so here are these young kids. Can they spread coronavirus? And it's all about relative risk. I know everybody gets tired of saying that word. They just want a yes or no answer. But the problem is there isn't a yes or no answer. So the best we can tell you is that if you've got a lot of health problems or underlying conditions and you're afraid of the risk, then sending your kid to that camp is probably not going to go very well. And you just have to decide how much risk you're willing to take on. If you can find a camp outside, does make all the difference. It is clear, from the protests, we're not seeing a lot of spreading events. That when you are outside, it just makes all the difference. So,
I'd also like to add. I'd also like to add that, with this virus, and we have seen this throughout, it seems to go against all the other dogma, all of other viral infections, whether it's GI viral infections, respiratory viral infections. Kids spread those very easily, and we know that. And this is a little bit different. So I think it's really good news, but we still want to wait for the final data on, how well or how efficiently are children able to spread that.
Yeah, as we always say, we'll be smarter in another 2 weeks. So, Bruce, I love the Royals.
And you love the Chiefs, too.
And I love the Chiefs. You and I have been at that
I know.
before. That's a hoot. So they're going to start playing baseball.
Yes.
Is it going to work?
I think it will.
Yes.
Here's my thoughts. I think sports it's important, not only to Steve Stites, but to many people.
My mental state.
For our mental health, and it gives us a sense of well-being, and certainly, we support our local teams and such, intercollegiate teams, and then we have youth sports and all of those type of things. But I think it needs to be done wisely. And if I look at what the Major League Baseball is doing, and also the NFL and collegiate sports, I think there's going to be some changes. And maybe it won't be 70,000 people packed into a stadium. Maybe it'll be 20,000.
Right.
In some cases, maybe it'll be no one. But I think that sports has to go on. And I think that Major League Baseball will figure it out. They've struggled a little bit getting this thing going.
They did struggle a little bit.
But hopefully they can get it going. And I know I'm looking forward to it.
The game's going to be on at my house as they start playing. I'll watch the Dish Elite Dinner. Royals game's going to be on.
Yeah, right,
as it always
exactly.
is. So.
Angela is asking if you're seeing any post-COVID complications with patients such as long-term issues.
Long-term issues, Dana, you and I can probably take that on. I know from a pulmonary standpoint, some people do have enough lung damage, especially if they get sicker and they end up on a ventilator, that they can end up struggling for 6 or 12 months in their recovery. It's interesting in the ICU, not only do you have lung disease, but you just get this kind of chronic malnourishment and weakness, and it comes on. It just takes time for that to get better time, good nutrition and good exercise, and rehab will really help. But you can have scarring in your lungs, and it can leave you permanently disabled. And that's one of the scary parts about COVID-19. It's really a scary part of just about any viral illness. It's unusual, but it can happen with a small number of folks that they can get so sick. Some people even progress to lung transplant. We had that question the other day. There had been a patient who had COVID-19 and actually did have to be transplanted. So those are the scary outcomes. But again, that applies to a very, very, very small percentage of patients. We think the actual case fatality rate, that is, the number of people who die from COVID who contract it, is probably around a 1% or less, because we think a lot more people have had COVID than we know. Dana, what's your, how about from your standpoint?
Yeah, I've seen patients in the outpatient setting after recovery from COVID. We know it's well documented that people continue just to have symptoms, whether it's malaise, just overall feeling bad, or whether it's chronic, little bit of shortness of breath. But the shortness of breath is probably better than it was 8 weeks ago. I saw a gentleman who was COVID recovered from 10 weeks prior. He was still having some shortness of breath, a little bit of cough. But yet I saw another gentleman who was 84, 85 years old. He had COVID 2.5, 3 months ago. And was perfectly fine. But we know you can continue to have symptoms, whether it's some muscle aches, joint aches, especially the respiratory or the lung type of consequences with just some shortness of breath, maybe some mild cough. I think you have to look as you go week to week, say, well, am I a little bit better than last week? We know that these complications will persist. And I suspect that with the things such as the lung problems, it's probably due to the inflammatory process that's been going on in your lung because of the infection and the immune dysregulation and all that stuff that does occur with the acute infection.
Yeah, it just goes on. It just takes a while. But severe influenza can act a little like that. Clearly, COVID is much more severe than that. So.
Cynthia wants to know if the University of Kansas Health System antibody test available to the public yet. How do you access it? Can I get it through a doctor's order?
You can get it through a doctor's order. It is available, but you have to have a physician order and really be a patient at the health system. It's not like there's a drive-by test you just come up and get. But it started on Monday. They're not that expensive to do. I say that I actually don't know what our charge is. But insurance, we know that Medicare won't pay for the antibody testing unless there's an indication. So it's got to be it can't just be I want to have one. The insurance and Medicare pay for it under more specific conditions. For example, if I have an exposure, I have a chronic cough, I don't know why it is. Okay, well, let's go take a look and see if maybe you did have COVID 3 months ago and we just didn't know. That would be an indication. You have to have the right indication. Dana, other thoughts?
Yeah, absolutely. The antibody test is not the end-all, be-all. In fact, I think it was just this week that a large group of English physicians wrote the journal BMJ, not really complaining, but voicing their concerns that just because you get an antibody test, it's positive, we really don't know what that means. And really, they stressed against using it for individual treatment purposes or direction to go as far as exposure and things of that nature. And more, it's really going to be better for large seroprevalence studies looking at the population and how the virus has kind of gotten through and penetrated through the population. But for an individual, it's really hard to understand exactly what that test means, and I think the public should understand that.
Yeah.
Margaret wants to know, it looks like we're in a surge or the numbers are going up. Are you going to postpone surgeries and procedures again?
You bet, though. That's a question, and we look at those things all the time. I'll tell you right now, the answer is no, right now. And here's why. When we had the first surge, or we thought was going to be our surge, we had our eyes on Italy and New York, Chicago, Seattle, and other places where the cases overwhelmed the number of ICU beds and the number of hospital beds. There were models out there that predicted Kansas City alone would have 6,000 patients with COVID needing a hospitalization, and we have 2,000 ICU beds here in Kansas City or thereabouts. Hospital. It's whatever the number is. We had 3 times more patients we projected than the actual bed number that we had to take care of those folks. That was going to be a big struggle. And in addition, we didn't have enough personal protective equipment. We didn't have all the processes that you all have talked about this morning ready to go. And so we're in a much different place today. What we're seeing, it's not really clear that the first wave ever really went down. We bent the curve, but coronavirus was still out there. What's happened is we've opened up society again. People have come back together. The cell phone data demonstrates that folks have clearly come back together. Maybe not as much as they did prior to COVID, but folks are a lot closer together again. And we're seeing the results of that. We're seeing more disease. We're not seeing the place where Kansas City is going to need 6,000 beds to take care of folks. What we are seeing is there's been a slow rise and then kind of a leveling off. And we hope it stays leveled off. But we're in a position right now where we can handle that a lot better. Our process is a lot better outlined. We've got a lot more PPE. We're a lot more prepared than we were before. In addition, delaying care is not good care. What we know is, and you guys have pointed this out, when you wait, sometimes things get worse for patients. And we know people were having heart attacks at home, they're having strokes at home, and they weren't coming to get the care they needed. So I think we don't have any plans to curtail surgeries. We don't have any plans to stop doing things or seeing patients in the clinics. It could change if we get overwhelmed, but I don't think we're going to get overwhelmed. I think we're going to see a rise, and I think how we act around each other, whether government tells you to do whatever is not the point. How much personal responsibility you have is the point. And if you can act personally in a responsible fashion, and more people do that, then we'll be fine. You'll be fine. And that's the answer that we really want. Bruce, other thoughts from your standpoint?
Well, I think you're preaching to the choir. I agree with everything you say at that point. And we want to obviously continue doing needed surgery, and all of our patients need these surgeries. And to delay things is probably not a good answer. But it is imperative for us to do it safely. It's imperative for our patients to go through the processes in a safe fashion and kind of understand all the things that you just enumerated. I can't tell you how much better all of us who are surgeons and work in the surgical field feel at this point, because we're now able to take care of our patients, which is the main goal. It's why we all go into medicine, is to make our patients better. And when we can't do so, it's tough. It's really tough.
From your standpoint in the clinic?
Yeah, I think, whatever the numbers do, if they go up or they go down, I think we all know the reality. We're going to have to learn how to provide medical care in this environment for at least 12 months or greater, who knows. Yeah. And I think all these processes that we put in place is really, as Bruce said, the hospital is probably one of the safest places a patient can come. People are still going to the grocery store and all these other places. I think what I tell my patients, this would probably be the safest place where we have all our processes very controlled. People are wearing the right amount of, personal protective equipment. So I think we're going to continue to provide that necessary care for our patients throughout this whole thing, because it's not going away, but we're just going to be safe about it and smart about it.
I think people do get worried about that whole COVID-19 thing. I don't want to go to the hospital because you have COVID patients. Well, let's think about that. We have never been safer. Our overall rate of infection is down here. I mean, we're doing better. It's pretty impressive. B, we cohort all the COVID-19 patients. So they're all in 1 or 2 wards of the hospital, one ICU and 1 floor area, so that we got all the folks there. So we can really direct that folks and make sure folks stay safe. So if you come to the clinic, man, those COVID-19 patients, they are far, far away. And I think to your point, you're not as safe in a grocery store by far relative to a health system where I promise you we're going to have masks, gloves, gowns, I mean, we've done so much stuff around this, it's remarkable. So, yeah, this is a safe place.
Kim and Becky have some questions for Dr. Hawkinson. Kim wants to know, you're with family, you're traveling, how are you keeping everybody safe?
All right, what's your bubble like, Hawk?
Yeah, that was actually a cause for concern for me coming to the family. Luckily, these family members they're med peds physicians, so they are very well trained in PPE and infection prevention, things of that nature. Understand what their bubble has been, and they haven't been with, around anyone else. The other thing is we continue to do things outdoors. There was a lot of hiking outside. We weren't going to restaurants or bars or anything like that. So we tried to maintain the bubble as much as possible. But other than that, that was a cause of concern compared to when I was just out in the mountain range and out more isolated, things of that nature. I was very cognizant of that.
That idea of being out in the mountains and out and outdoors and being isolated, that's the best. It's really it's a great way to stay safe. And your kids are with you. They're always inside your bubble, so that doesn't change. It's really those spots and how you travel in between. Y'all have heard me say I go down to the Mark Twain National Forest a fair amount in southern Missouri, and there's just not a lot of people out there. It's a pretty special place. You can hike and float and fish and do all sorts of stuff and really not see anybody all day long if you go to the right spot. So I think it's really about the choices that you make about how you travel that keep you safe. Because I'm going to bet you have some hunting trips coming up this fall.
I do, and the nice thing about that, except for my dogs, it'll only be me and the dogs, and maybe a few birds if I'm lucky. So, no, I'm not going to stop my hunting activities. I think it's very safe.
Yeah.
But I do think your points are well taken. It's if you have your family is all cognizant of the risks and are doing the right things, I think it's very safe.
Yeah.
I have my daughter visiting us this week, who's 30 weeks pregnant. Hello, Rachel out there. Anyhow,
Hi, Rachel.
Anyhow, she's very careful, and of course, because she's pregnant, she's extra careful. And I think that if you have those type of individuals surrounding you, I think it's very safe.
Where are you going this summer? You headed out of town doing anything?
We always try to take a big trip over the summer, usually somewhere international, but we're not going to do that this year.
Right.
We are going to do something, it'll probably be a little bit different flavor, but we'll get the family out, maybe a road trip somewhere where there's not a lot of crowds, but we'll do something just to kind of, decompensate a little bit. So.
Yeah.
We have a couple of really good questions, but one quick one for Hawkeye is, what do you have in your bottle that you're spraying when you've been on vacation? They want to know what your secret sauce is.
Oh, Hawkeye, what's in that secret sauce, brother?
Another part of the silver lining to all this COVID is that there has been repurposing of companies that have already been making. So we have gotten some Rieger hand sanitizer. It's the alcohol, the fluid, not the gel, but the liquid. I don't have the Rieger. I have another brand that was sold at my local hen house. I really like the alcohol spray. A little bit better than the gel because I can also spray it on surfaces and things of that nature. But basically, it's just the big repurposed, vodka distilleries that are now making hand sanitizer. And I think it's a really good product, and I will continue using it in the near and long-term future because I believe it. It's nice. It's easy to use. And again, you can spray it on surfaces, but also your hand.
Yeah, and hats off. We've said before, BKC, and some of these companies are from Kansas City, like Rieger's. They've done a great job. I've got this stuff in my house, and there we go with the surfaces. Smells good. I'm not going to say that it tastes good because it's not supposed to taste good. We don't recommend drinking that version of Rieger's. There's other versions of Rieger's that are pretty good for that, but perhaps not the hand sanitizers or the spray bottles.
Okay, Linda wants you to explain the rationale to COVID swabbing of patients prior to surgery, and do you have to do it if I'm going to get a procedure?
All right, let's do that. Well, let's start with Dana. Just give us a little background, and we're going to turn to our experts here.
Yeah, so there was pretty good evidence before a larger paper came out, but a larger paper has come out recently, and it shows that perioperative, meaning around the operative time, whether that's a few days before to a few days after, if you are COVID positive, you have a higher rate of morbidity and mortality, which means complications and death if you are COVID positive. So that's the main reason that we are swabbing. It's for your safety, it's for the patient's safety. That also does help, again, with healthcare workers and proper PPE. but mostly it's for patient safety, because when you are having a procedure, no matter how small, and Dr. Toby and Dr. Sayed can talk about this, it's not small to you. And so we want to make sure that you are the safest you can be and you have the least risk of complications after surgery. And that's why we swab and look for COVID infection.
And just to say, because patients can often be asymptomatic, we wouldn't know that. We actually take a test on every admission that comes to KU, because if you come into the hospital, we want to have the right PPE for you and for everybody around you and not have you spread it. So we do that differently based upon whether or not you are COVID positive or negative. And because we have asymptomatic patients, and we usually admit several people a day who are asymptomatic, and when we test it, we have to treat them differently. And Bruce, I think that has been important in the operating room.
It is. Everybody gets tested within 48 hours. And after they're tested, they're supposed to sort of self-quarantine. And the idea is to protect the individual patients, as Dana was saying, but also to protect everyone else, individuals they may come into contact with when they come into the hospital, other patients. And so I think it's been important. I'm amazed at how well the patients have tolerated this extra burden upon them in order to get their surgeries.
Dr. Sayed, you mentioned a little bit ago about the procedures and things in your practice. Do people have tests before that?
Yeah, that's a good question, and we really did take a long, hard look about that. So essentially everyone will get screened. 100% of patients get screened when they come in for a procedure.
And by screening, that's a questionnaire.
Questionnaire, temperature checks, all those standard things, and wearing proper PPE when they come in, as well as the staff. But what we found is, 99% of the procedures we do not require anesthesia. They're usually less than 10 to 15 minutes. They're done on an outpatient basis. So these aren't procedures where if you did something on a patient that they would get critically ill if they had coronavirus. So, and as Dana said, that's really kind of the big thing we're trying to avoid when we test these patients. So, unless a patient's going to get a general anesthetic for their procedure, be hospitalized, we typically will just do the typical screening and we'll take all the appropriate precautions, but we will not do a test.
All right. Jill.
Cassie, if someone was once positive, are we safe to vacation with him now? Separate rooms, mostly outdoors?
Is it safe to vacation with somebody who has been a positive COVID patient? Dana, I think it really depends on how long it's been, and as we know, if you're asymptomatic, after about 10 days, you really don't shed and spread. Shed and spread, that's pretty good. Shed and spread the virus so much. I just made that up.
Trademark that. Yeah, absolutely. We don't have a lot of data. There's a paucity of data, but from what we understand from what is out there and people who can actually culture infectious virus, it seems to really drop off after the first couple days of infection. And then by about 10 or 11 or 12 days, from the samples that they've taken, from the studies that they've done, they haven't been able to actually culture infectious virus from the upper respiratory tract itself. So to your point, Steve, yes, the further you get out from your original diagnosis or when your symptoms originally started, you are probably going to be considered COVID recovered. Now, we know that if we did a PCR swab, the nasal biopsy or the brain biopsy test to look for the virus, we're probably going to be able to detect the RNA, but that doesn't necessarily mean that you're infectious. So the further you're getting out from your original symptoms, you're probably going to be considered COVID recovered, and you should be safe. But again, that is not a reason to not use hand hygiene, physical distancing as much as possible. You can always do an overabundance of caution if you wanted. Wearing face masks in the household has shown to be really reduce the risk of spread. But once you're COVID recovered, you really should be safe to travel with other people, especially in your family.
They're probably in the bubble anyway, so.
Carolyn's got a good follow-up question to that. She said that her husband had a friend who tested positive because he had to be tested for work. And he goes, I'm not sick now. I was sick back in March, but I'm not sick now. And she wonders, is the positive test he has now from being sick in March?
Could well still be positive from that test in March, because you point out, Dana, you can still shed the virus for a while, and some people don't clear it. And as we get older, we tend to clear the RNA a little less rapidly. Younger kids tend to clear it a little faster. And so I think you can still be positive even from something in March.
Kathy, she's got a bus tour for 10 days scheduled in October. What's your advice? They're at retirement age.
Well, let's just hope you have vaccination and effective therapy. I would, if I was of retirement age, I think a bus tour is probably one of the places I would not want to be. It's right up there with cruise ships, Dana.
Yeah, absolutely. Probably on a bus, you're going to be longer than a plane ride of 1 to 2 hours. It's an even smaller confined area. I don't even think they have the air circulation. I don't know this, but I don't think they have the air circulation on the buses that they even do in the airplane. I think it's a very dangerous proposition. I think you definitely would need a mask. I think everybody would be needing a mask, as well as eye protection and a lot of hand sanitizer available. But overall, I think that the confined space for the amount of time in the close proximity to everybody else, I think makes for a very dangerous proposition.
Yeah, I'm moaning and groaning on that one. Too much shedding and that doesn't sound right. Next question.
Yeah, they're coming in so fast. I had one from Diane. Here it is. And I don't know if this is the last one or
This will be the last question today.
It's a great question. Diane is asking, what is the definition of a continued wave that we are now in versus opening up a second wave? She wants to know what's the difference.
What's the difference?
People say,
Dana, this is a hard one because the reality is that there is no clear distinction. People throw around both terms, and you hear different people describe which one you're in. What do you think?
Yeah, I think we're still in the first part of the infection phase. I think you can test as much as you want. I think you can not test as much as you want. You can slow down testing, do whatever you want. The fact remains that the virus is out. We know that people are spreading it. There's more and more infections. We are seeing more and more reports now of other health systems, other hospitals around the nation having the surge capacity really brought to the brink with not enough rooms, not enough ventilators, not enough important drugs to keep you comfortable on the ventilators. I don't know about a surge anymore. I think the virus is just continuing to exponentially spread. It's just a matter of semantics. The main idea, the main point is that the virus is out there. It has been out there since at least, March when we started the shutdown. And since we've reopened and people have gotten out and people have gotten together in groups, it's just shown that it has continued to spread and that will continue to do so.
And actually, I think it becomes a semantic point, meaning it's just words. The reality is, if you stand on the edge of the ocean and you watch the waves come in, they come in, right? It's a big waves, small waves. That's this virus. And the waves, the thing that affects the waves is not the gravity or the moon. It's really how we behave. And if people don't have super spreading events, so they're not in places where there's a choir practice or a big church gathering or, a bar or things like that, or a meatpacking plant, the nursing homes, if you don't have good, all those things create waves, and that creates a rise in the number or a fall in the number. We know that socially distancing works. We know that wearing a mask works. And we know that washing our hands and not touching our face work. If we do those things, the waves are small. If we don't do those things, the waves get bigger. The original surge models were kind of what happened in Italy when things just got overwhelmed because people they just didn't know enough at that time to shut everything down. And so with societal behavior and how close people were together, there was a massive surge and things got overwhelmed. That's really not what happened here in the United States, outside of New York and Seattle and some other areas. In the Midwest, what we've seen is more just kind of wave, 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 all depending upon how we behave. Well, as we finish up this morning, I'll look at our two guests who, guys, you're welcome back anytime. You did a great job. Final thoughts today?
Well, it was good to be back and working again. And I want to say thanks to the leadership of the healthcare system here. There's no question that you guys have been the leaders in this region. And, of course, what I do is I always just to defer to you when people ask me these questions like we're coming. I say, well, you maybe ought to talk to Dr. Stites.
Yeah.
We've been very lucky. He's a pulmonary specialist, and we've got someone like Dana who's an infectious disease specialist kind of running the show. It's really been good to kind of watch this from the outside.
You're way too kind. Thank you for all the great work you do. And this is the guy who's kind of birthed a lot of our sports medicine movement here. So thanks, Bruce. All right, you're the president of the American Society of Pain and Neuroscience. Final thoughts and to say, especially to the pain patients out there.
Yeah, I think I want to just say thanks to our patients for having trust in us and continuing to kind of seek care. I think, what the coronavirus has really forced us to do is really kind of optimize the way we provide care. So if someone's sitting there, you have chronic neck pain or it's just kind of just starting neck, back, knee, We can do a telemedicine visit. You can see a board-certified pain specialist, at the comfort of your own home. We can figure out if this is a serious thing that requires inpatient care or in-person care, and we can triage you appropriately. I think one of the nice things I've noticed now is that being involved in care within a health system. We have multiple locations throughout the city. Patients can minimize travel. We have testing locations all over the place. So it's really, I think, this health system really provides the best opportunity for care for patients in our region.
Yeah, thank you. You've done great work, and we appreciate you, both of you guys, so much. Dana, you traveling again today back home?
Yeah, I'll be driving through the rolling hills and the wide open skies of Kansas and the wind farms. I'll be back in studio to physically distance with you tomorrow. We'll continue to maintain those safe practices that we're doing with the hand sanitizer when getting gas or getting drive-through. But it should be a good drive, and back to town tomorrow.
All right, well, travel safely. Hey, tomorrow it's for our Friday question session where we'll spend most of the day just trying to answer questions out there. And our blood center folks will be back to talk to us about how the blood drives are going here. There's one right here on our campus this week. Also today, just kind of wrapping up, Beverly Van Horn made a mask she's wearing. We're trying to feature the mask wearing out there because we know how important that is, and trying to make people feel okay about wearing masks because it is the right thing to do. She also has made masks for family and friends. She also says she uses hand sanitizer and socially distances. Thank you for showing how safe you can be and how all of us can be kept safe. We're in it for a while. Not going to go away right away. It's pretty clear that warm weather's not going to make it disappear. The thing that's going to keep you safe is yourself. How you do is really going to be responsible for how you do. So don't shed and spread. Stay home, be safe, and we'll be back here tomorrow with you. And until then, there's still no place like home. See you tomorrow.